It is a 15-year-old man that presented a blunt abdominal trauma. The abdominal CT scan showed a grade 4 pancreatic neck laceration. In the axial section, it can be seen the pancreatic neck laceration marked with a yellow arrow, and also in the coronal section of the CT scan. It is shown the pancreas injury scale with the different grades of pancreatic affection, being grade 1 the minor and grade 5 the most serious. A 3D CT scan reconstruction is shown where the complete pancreatic section is observed at the level of the pancreatic neck. The case presented a vascular anatomical variant, being the right hepatic artery a branch of the superior mesenteric artery, as it can be seen. The patient presented a grade 4 pancreatic laceration, so a laparoscopic distal pancreatectomy with splenic preservation was proposed. The patient was placed in a supine position with open legs. The trocars were placed as it can be seen in the image. The surgery began with the access to the omental cavity, followed by the access to the lesser omentum. Then, the stomach was suspended using 2 umbilical tapes to achieve correct exposure of the pancreas. The pancreatic neck involvement seen in the surgery was also observed in the abdominal CT scan. The common hepatic artery was identified and dissected, as it can also be seen in the 3D reconstruction. In the next step, the lower edge of the pancreatic gland was dissected at the level of the pancreatic neck, confirming a complete section of the pancreatic neck that matched with the findings described in the abdominal CT scan. Pancreatic section was completed with bipolar coagulation, being the anterior face of the mesenteric-portal confluence exposed. Surgery continued with a section of the short gastric vessels and splenic flexure mobilization. It can be seen the presence of pancreatic intra-abdominal fluid. In the next steps, the lower and upper edges of the pancreatic gland were dissected. Then, the splenic artery was identified and referenced with a vessel loop. The splenic artery and vein were dissected and preserved. The small caliber branches from the splenic vein were sectioned with bipolar coagulation, and the larger caliber ones with hemologs. This surgical procedure is technically feasible and safe in experienced hands. After completing the distal pancreatectomy with splenic preservation, the pancreatic remnant was sutured. Then, hemostatic agent was placed in the surgical bed. In the final image, we observed the pancreatic remnant, splenic artery and vein, and the spleen. The surgical specimen was removed with an endobag. A suction drain was left in the surgical bed. In the postoperative course, presented a biochemical leak treated with an adequate abdominal drainage. It was discharged home the 15th postoperative day without abdominal drainage. Pathology confirmed an acute pancreatitis with hemorrhage and necrosis.